Thank you, Piyush. So it's a very important and very exploding topic for every one of us, how to handle disasters in nephrology with exploding number of kidney patients, CKD patients, consequent transplant patients, and so on. So let's begin the session, and thank you very much, Piyush. May I request Mr. Saini to start with the topic, please?
Thanks, Dr. Manali, for giving me this time. And thanks, Dr. Khalkar, for inviting me for this meeting. Doctor amongst a non-doctor being here amongst doctors. हिंदी में कहते हैं बेगानी शादी में अब्दुल्ला दीवाना. Not to undermine as to what we have been able to see. And as far as disasters are concerned, not many things we have already seen, beginning with 2001 earthquake, where we had taken a team and we had personally seen the type of challenges which were faced by most of the responding units. That was the we'll say that the beginning of the complete change which happened in our country. Although the things started unrolling worldwide in 1990 itself, and the Armenian earthquake in 1988 was the threshold when people started identifying challenges basically with nephrology. And as such, in fact, there are many areas within disasters which were not explored, were not looked at, were not identified as the need for people who basically will be needing as assistance when they get extricated from collapsed structures. Turkey primarily was part of the INSARAG unit, and SARAG is the International Search and Rescue Advisory Group, which keeps on advising their own group heads as to what they need to be prepared for and what type of expertise they must have within their teams when they arrive for any international search and rescue mission. We did not have any such teams, and it came much later, around 2008, when we started the NDRF. And this particular issue or this challenge, which we normally came across, has been here in Nagpur also. So I'll start with only telling you first a few things about disasters. That there are many types of events which can be expected. Managing a disaster is beyond our capacity. Managing resources which are required for assisting the people and reducing the time of recovery is what is within our domain. So our basic motive is to, as early as possible, to mobilize resources, help the people, get them what they need, and subsequently ensure that we have a higher survival. Because the higher the survival, the lesser is the period of recovery. If you have a large number of deaths, large number of people affected, community totally disturbed, you will find that the entire recovery itself will take years for things to get normalized. Even if today, if you go to Uttarakhand, things are not in the same manner as what they were previous to when the flood disasters happened. But what we normally experience during such type of events is that the man-made structures normally are the ones which face the brunt of the damages. And by force of whatever nature forces we have come to believe that people don't die because of disasters, but they die because of actions which the humans undertake. And this is where the vulnerability comes in. A vulnerability of individual primarily because of certain things which are there existing and which primarily we do post any particular event which happens. So in a collapse structure, what was noticed was In the first part of mission in 90s, it was that you send in a team, they dig, they extricate and rush that individual to hospital, because that is where the most of the medical assistance will be available. There are a lot of things which were observed at a later stage, though I think many of you must be making a presentation and talking about these things. But there are two things which happens when a structure collapses. One is a person may get a crush injury. So if you may have a crush syndrome victim lying at a building collapse for a very long period of time. Either he is extricated within 24 hours or maybe 48 hours, within 72 hours, or maybe even after that. A lady was rescued after 7 days from a collapsed structure in Ahmedabad city by the firefighters, and she was alive. She was taken to hospital, but after 2 weeks she died. And she died because of renal failure. Why she died? It became apparent to many of us at a much later stage. And earlier, in fact, people never knew that a lot of things can happen to an individual as far as his body organs are concerned or not. And that is where the NDRF today has a medical team which goes along with them. As I said, we need to have fluid resuscitation to be provided on site. So a nephrologist may be expected to be working along with the rescue team and have the same capacity to enter a particular confined, make an assessment for that victim, and then subsequently start the fluid resuscitation from wherever that person is lying. A very hell of a difficult job for all of you, but certainly is the need. Why it is a need? Because it was undertaken as a study, and it was found that when an individual usually is lying in a buried state, his mobility is restricted, his level of activity is very reduced, and moreover, he is not eating or drinking anything. So fluid loss as well as the other things associated with body movements are totally restricted. His blood pressure goes down, and this primarily results in a lot of psychological impact or on the individual also, where this person believes whether he'll be rescued or not. And this, the intention or the idea of being rescued primarily starts getting dissipated as the days pass. As I said, that lady in fact survived for 7 days, but usually after the 5th day, the expectancy by most of the rescuing organizations starts dropping. Our teams of NDRF have already come back from Turkey on the 6th day. We were not there for more than 5 days because the possibility of any live victims being in there in a buried state was very, very remote. And there was many other challenges which they could not face. So this is what primarily was found. And what we need to understand is that whenever a rescue team approaches an individual who is in a buried state, who has been absolutely idle with no mobility, no access to any food or water, the sense of elation in that individual, yeah, main to bach gaya. So that sense of elation shoots up his blood pressure, and that happiness quotient is what results in huge amount of toxins getting mixed with his blood. I think you must be knowing about this factor. Hypokalemia, in fact, is the term which is normally used, which can occur in such a case. Am I right? I'm not a medical officer. That's but this usually can happen. Then you have the acute crush syndrome also, which can happen. So this is the first challenge, that in case there is a building collapse, how assistance can be provided during such events. And don't look at disasters only. Buildings do collapse in Mumbai even during rainy season, and these have also happened in Nagpur. In one of the building which collapsed in on the Ghat Road. In fact, we were there for 2 days. There were 3 people who were brought alive. One person had a complete amount of hand crushed. So he was taken to GMC. After 48 hours, I mean, within when he was taken to hospital within the first 8 hours itself, there was an amputation which was conducted. And but due to again complications, he died after 48 hours. What was the reasons? We do not know till date because nobody talks about it. It's only the medical people who will be able to understand as to what happened with that guy. He was alive. There were 3 people who were brought alive. Total were what 9 who were buried. 7 we extricated, or 7 were brought out dead. In fact, at a much later stage. So it has happened very close to our places also. The other part, in fact, during such disasters is people who are already chronic kidney patients having access to dialysis. And moreover, and when I talk about dialysis, we were also talking about this particular facility to be created or not. But providing a facility on a regular basis for such victims with need daily dialysis or about 72-hour dialysis procedures, which you normally may provide, that may be necessary to be organized. Dialysis is something which also will be needed by any person who has been brought out in the first 24 hours. So depending on his physical condition, assessments will be needed, and subsequently we will have to provide, even if we go for fluid resuscitation, we may be required to also carry out dialysis of such victims. So all these facilities which we need to provide is what you need to think about how we can. There has been, I think, an effort which has been made by International Society of Nephrology. You must be aware about this. There's a what do you call a team of IRDT, a disaster team which have been made, and I think an effort can be made to start here. Anywhere in the country, I think such team don't exist. Is it there? No. So why not start with Nagpur? With the topic given to you, you can organize a team which primarily can be identified, at least, because during disasters, we should have somebody who can provide this assistance. And this is where on what you call on timely basis, on shift basis, I think people can be part of the team, and accordingly, whenever things go wrong, this can be needed. I'm not aware of anything which can be happening beyond any other disasters, but floods is what we usually have more. And earthquakes is something which is very rare, but the next earthquake is expected in India, somewhere Uttarakhand or Himachal borders. Let's see what happens, and God bless, nothing should take place. But if it does, we have the same situation what happened in Turkey in the northeast, where 2 plate boundaries are compressing each other and pushing towards China. So it's the same level of things which we have already seen here in Turkey. And all these plates do have various pressures which they generate on each other. So anything happening somewhere can obviously initiate an event at another place also. But what we need to understand is that you people are experts on this. You need to understand and start organizing efforts where let's get prepared for any event which can happen. It may be big, but let's start small. Even if a single event happens with expertise which is available and being provided to victims, I think will go a long way in ensuring that whenever anything big happens, we do have such teams multiplied. Because in disasters, or when we talk about disaster management, management starts with the first responders, elements which are already existing. We always call them that these are on duty. So the GMC with their own strength of doctors will be certainly something which is available. There'll be some which will need to be called from outside, because hospital itself may need more human resources. And subsequently, if such availability of human resources doesn't come, managing a bigger event will become very difficult. So thank you for inviting me, but I'll be surely be part of the entire group. Anything which you would like to ask, we'll rather have a discussion on this. Thank you very much. Thank you.
All right. So let us hear something more. Maybe I think Dr. Ukalkar sir would like to add something or ask. Convener? Next speaker. Okay. May I invite now our respected VL Gupta sir for his next talk on preamble disasters and kidneys.
Good evening, friends, and I'm delighted to be here and grateful to organizers and Nephrology Society, Dr. Ukhalkar, for giving me the chance to talk or to introduce the subject. I think Mr. Saini did an excellent job, and he did mention two very important situations where what we nowadays coin a disaster nephrology should come into picture. You have to be very aggressive. And these crush injuries or crush syndromes are so common, and they are the commonest, probably the manifestation of polytrauma that occurs during disasters. And he did mention about the potassium load that creeps in and can kill a man on spot if it goes beyond 12 or 13 milliequivalents per liter. I had an opportunity of treating such a patient where the potassium, he had a total crush syndrome, and potassium input was so high that he never came down below 10 milliequivalent despite the continuous dialysis being given. So there was a source where all other measures were done in that patient, but you see the hyperkalemia persisted. Such was a potassium load there, and the only chance you can do justice to this patient is to dialyze them adequately, aggressively, not about the daily dialysis, or they probably few days he needs a continuous dialysis procedure. So that's one. And there are more reasons, like you also mentioned about the fluid resuscitation, which can prevent renal element of AKI that can add to the kidney and disaster syndrome. Friends, I'm not an expert on disaster and things like that, but with the topic that has been mentioned here, disasters and kidney management, or disaster and kidney, it's very relevant that we do introduce this subject to experts and let them elaborate. So I really don't have any formal PowerPoint presentation at that point in time, because I'm just going to give you a rough sketch of what I think about this disaster and kidneys. It will not be out of place to mention that disasters are occurring more and more frequently than ever, right? About 56% of our land mass is prone for earthquakes. That's what, I mean, I did read it and update myself, referring to the 2009 document of Government of India. Right. Our long coastal line and area are prone for storms, hurricanes, tsunamis. Significant land mass is also prone for landslides. Especially you mentioned about the north, Uttarakhand, Kedarnath, and those areas, Devbhumi, where these landslides, and terrific thing occurs at Kedarnath, you all know that, killing thousands of people. Besides annual floods coming regularly in some areas, likely to increase as glaciers are melting fast because of the global warming and climate change. Recently, I read in a lay press that there's some relation of climate change and global warming with the frequency of earthquake also. I don't know how that correlates scientifically, but that's what the lay press mentioned. So that is disastrous. The pandemics like COVID-19, which we recently experienced, stresses our healthcare infra and logistics to large extents. Man-made disasters like war, riots are commonplace. Use of weapons of mass destruction, like nuclear, biological, is always lurking out there. Recently, we are on the high alert about this nuclear disaster that is always there. And probably everybody remembers and has seen Chernobyl tragedy that occurs in Russian nuclear plant some decades back. There is a danger of large and industrial accidents and mishaps like the Bhopal gas tragedy, which we all have seen. So our preparation to face this disaster has to be comprehensive and updated. Keeping this in mind, World Kidney theme this year is very appropriate, that we are preparing for unexpected and supporting the vulnerables. Now, this is very important. There is a vulnerable population, subset of population in our situation who need a special kind of support during disasters. Why I'm saying that? Because patients with kidney disease contribute to this real vulnerable population. In order of priority, following groups can be identified. Patients of chronic kidney disease on maintenance dialysis. Patients of chronic kidney disease on conservative treatment. They are yet to initiate dialysis themselves, but they are maintaining stable life on supportive treatment. So that's one. And third is CKD, who have received renal transplant, right? Now, first group, patients depend on dialysis support for their survival, right? Any disruption can spell disaster for them. Second group, patients who otherwise are stable can get destabilized and may need dialysis support during time of disaster. And because of exposure to various risk factors, the transplant recipients might head on to graft dysfunction and ultimately losing the transplanted kidney. So this is very important. Cases of AKI, as we discussed just now, crush syndrome, prerenal element, can occur during disaster and will peak because of polytrauma, burns, sepsis, prerenal elements, crush syndromes, and things like that. And they may also need an urgent dialysis support. So we have two situations which can confront management teams and planners. One is that the burden of illness will abruptly increase, right? And more patients will need probably dialysis support, more than what we are seeing at present. The disaster time may spell another peak of people who might require dialysis support. While dialysis facilities may get destroyed or simply become inaccessible to people who need to seek dialysis in this situation. So these are the two issues, and the serious issues that disrupt the services are the destruction and damage of healthcare facilities or dialysis units, the loss of trained human resources, right? Either they are inaccessible or something bad might have happened to them and they are not available for giving services of dialysis, providing dialysis to the people. Scarcity of supplies, right? Disposables and medicines. Disruption of power supply, very common. I mean, that's, you need a power, you need a water to perform a dialysis. There may be disruption of water supply as well. Collapse of transport and conveyance, because, you know, the person who needs to travel to or go to the dialysis facility needs some kind of conveyance, and that may be seriously disrupted in this situation. And the very important is loss of communication, right? We are in the area of mobile phones and nets and internet, and we no more rely only on landlines. But that's with collapse of mobile towers and things like that, that service also may get disrupted. So serious thought has to be given. Addressing each one of the above and preparing for emergency backup plan, which will be in place at the time of disaster, will make things easier. I mean, at least it will ace some. I am not saying that this is a complete solution. I mean, the solution do not stand during the time of disaster. Something happens which you have never foreseen. So we have to think about easing the situation and providing the best we can do for this patient. Suggestions from all leads who are leading discussion today will help us to draft the emergency backup plan for these patients or vulnerable population, and we will draft them and tune up and probably recommend it to the stakeholders and policymakers during that point in time. Professional societies like the Nephrology Society can take a lead and help stakeholders and policymakers to prepare a consensus document, which can be, of course, improved upon taking the inputs from the experts in the area. My suggestions will be that we should identify several dialysis centers in different areas away from each other, right? With the hope that some of them will be least damaged or will not be destroyed. So they can be be useful at the time of disaster, where other units have really seriously been affected because they can't provide service for that time. Backup power supply, generator, and a water supply with the adequate storage facility as such an identified dialysis unit should be made available so that they can sustain in case the supplies are disrupted. Buffer stock of disposable and medicines. And there should be a mechanism of pooling the human resources, very important. That you may not have the dialysis technicians, staff nurses, and assistants to run these services. Leave apart the nephrologist. They are the key people who are responsible to do a dialysis very smoothly. So we should have the list and the contact number and addresses and how to get them back, and in case of emergency, pull them together at such a designated dialysis units where we can see that there's no disruption of the services to patients who are on maintenance dialysis, or probably more rapidly, a patient who acutely needs dialysis. It's life-saving for him, right? Now, I sometime back saw in Bombay some trusts running the mobile dialysis units. See, the big van or bus-like thing is equipped with dialysis machines, couple of them maybe, water supply, power supply independent. We can mobilize these machines and take them to areas where nothing is accessible. That probably is the situation, that some dialysis support can be provided to people who are on our priority list. And we can ease the situation to some extent. Creating emergency communication line, very important, because you need to contact those people, tell them that this dialysis is available here. And if nothing works, we should have a provision of satellite phone, where probably, unless somebody shoots up that satellite, will keep on working in case towers collapse and net contact is lost. So I think there are people, personnel working in front areas in high altitude do have provision of these satellite phones, and which can, I think the communication is of vital importance. Communication and conveyance. You need to revamp whatever transport system is left along with you, so that you will move people to dialysis unit or move dialysis unit to people. So that's how you should come in. Use of internet and social media for communication, and revamp dialysis facilities, the transport and conveyance facilities. So these are a few thoughts. I think these are very raw, and have come from a novice like me. We need to sort of inputs from the experts who are participating today's deliberation, all lead faculties, so that we can really prepare a document worth. Thank you, ladies and gentlemen.
Very privileged to have experienced. We at Nagpur, we are very privileged. We have Gupta sir, who is a nephrologist as well as epidemiologist with a great vision. And we expect to have a beautiful platform, at least to start the foundation of this platform for handling disasters under guidance of Gupta sir. So let us now move on to our next speaker. I invite Dr. Sureshri Pandey. She will be talking on prevention of acute kidney injury.
So coming to the topic which is given to me, I will be restricting only on acute kidney injury, prevention of acute kidney injury in disasters. Yeah. So to introduce the topic, AKI is frequent in disasters and it shows a wide variation with regards to the spectrum, etiopathogenesis and management strategies. It should be remembered that the victims of disasters, they have associated injuries and related comorbidities as well. And as we all know, AKI has diverse systemic consequences in all the systems of body, which is not limited to just fluid retention, which leads to respiratory or circulatory failure, persistent systemic inflammation, neurocognitive defects, anemia, acquired immunodeficiency, microvascular injury, thrombosis, and acute respiratory distress syndrome. Efforts to extricate trapped victims may be futile if the means to resuscitate and treat these rescued victims are not available. And the common cause of death is due to crush injury, hyperkalemia, and inability to provide dialysis in these disastrous settings. So let us just revise the definition of AKI, which was proposed by KDIGO in 2012 when we had a standard definition. So AKI is defined as any of the following with increase in serum creatinine by more than or equal to 0.3 within 48 hours, increase in serum creatinine to more than 1.5 times baseline within prior 7 days, or urine volume less than 0.5 ml per kg per hour for 6 hours. And the staging of AKI by KDIGO in 2012, which has incorporated the rifle as well as the Akin classification of AKI and put it into 3 stages, which use the parameters of serum creatinine and urine output in a gradable way to define the stages of AKI and the severity of AKI. So to define the spectrum of AKI after disasters, let us talk of crush syndrome separately and the other etiologies which can be associated with disasters. So as already it has been highlighted by the earlier speakers about crush syndromes. So crush syndrome is one of the commonest pathogenic mechanism which is responsible for AKI and which is preventable to a large extent. So earthquakes, wars, other destructive disorders, collapse of building, these all are the conditions in which we get crush syndrome as the maximum, and the underlying mechanism for this crush syndrome, as we all know, is a muscle injury, muscle edema, intravascular hypovolemia, further muscle injury, myoglobinuria, and heme pigment related injury to the kidney. Other etiologies which are there in AKI, which are found in disasters, are pre-renal conditions, wars, earthquakes, other destructive disasters, and the silent disaster which we have in this area is the heat stroke. Here there is hypovolemia and massive bleeding which can happen in mentioned conditions due to trauma or gunshot. There is shock which sets in prerenal kidney injury which further progresses. We can have post-renal conditions which can be responsible for acute kidney injury like supra or infravesical obstruction due to pelvic trauma, hematoma, and foreign bodies, and intrinsic renal failure which can be there because of the progression of prerenal to an ischemic ATN, nephrotoxic ATN due to shock, sepsis, nephrotoxins, infections. We have been witness of COVID-19 related acute kidney injury recently, and transfusion reactions which could be responsible for intrinsic renal failure in disasters. So let's now revise ourselves that KDIGO has identified these interventions right from the high risk stage for AKI, and these are the general principles which apply to the AKI in disasters as well. So they include discontinuation of all nephrotoxic agents when possible, ensure volume status and perfusion pressure, consider functional hemodynamic monitoring, monitor serum creatinine and urine output, avoid hyperglycemia, and consider alternatives to radio contrast procedures. So to talk about the prevention of disaster related AKI, we will discuss under 2 main heads: the general principles for managing AKI and the prevention of crush injury related AKI. So let us just quickly go through the guidelines and get us accustomed with the let us revise the concepts of basic principles for managing AKI, which remain applicable even to the AKI in disaster-related AKI. So using isotonic crystalloids rather than colloids as the initial fluid management for the expansion of intravascular volume in absence of hemorrhagic shock. And they recommend the use of vasopressors in conjunction with fluids in patients with vasomotor shock, which is not responsive to fluid resuscitation alone. They suggest using protocol-based management for hemodynamic and oxygenation parameters, targeting plasma glucose of 110 to 149, and not using diuretics to prevent AKI. Diuretics should only be used in management of volume overload. When it comes to the drugs like nephrotoxic drugs like aminoglycosides, better to avoid if it's not possible to avoid use in a single daily dose with level monitoring, and the lipid formulations of amphotericin B should be preferred rather than the conventional formulations. When contrast studies are required, volume expansion with isotonic sodium chloride or sodium bicarbonate solutions, and not only resorting to oral volume expansion is what we usually practice, and this is the recommendation by KDIGO. This is an acute disease outcome quality initiative conference which was conducted in 2016 in Hyderabad, where they talked about the prevention and therapy of acute kidney injury in developing world. The first question which was answered in this conference was, what should be the initial management of patients with suspected AKI? So every patient with suspected and or persistent AKI should be assessed for volume status, as volume depletion is one of the major risk factors for AKI. And the assessment of volume has to be in combination of history, including medications, physical examination, lab testing, and hemodynamic parameters, both static and dynamic, should be performed to obtain the best information for fluid assessment. And clinical reassessment is the key concept for fluid resuscitation. These were the minimal parameters for fluid assessment. This is at the community level and at the hospital level. So at the community level, fluid resuscitation, response to fluid resuscitation, fluid challenge, furosemide stress test, alteration in mentation, hemodynamic parameters like blood pressure, heart rate, the capillary refill time, urine analysis, urine output, and fluid balance charts. And at the level of in hospital level, response to vasopressors is one thing which is added, and these are the minimal parameters for fluid assessment which we can do in our settings easily. These are the definitions which they have proposed. The fluid bolus giving 500 ml of a crystalloid over a maximum of 15 minutes. Fluid challenge giving small boluses 100 to 200 ml over 5 to 10 minutes with reassessment to optimize tissue perfusion. Fluid infusion, where a continuous delivery of IV fluids is given to maintain homeostasis, replace losses or prevent organ injury. Maintenance fluid is the fluid administration for the provision of fluids for patients who cannot meet their needs by oral route, and many more definitions which were put in this are daily fluid balance, cumulative fluid balance, fluid overload, response, persistent AKI, complete reversal of AKI, and development of an acute kidney disease. So the discussion for AKI in disaster cannot be complete without talking about the resuscitation of crush victims in order to prevent the crush syndrome. So as it was discussed earlier by the previous speakers as well regarding the importance of on-site resuscitation. So why this is there? Because there is a therapeutic window where intensive fluid management can restore the renal function, and it can actually eliminate the need for dialysis and the progression of AKI, and there could be a spontaneous recovery of renal function or a prevention of AKI with aggressive, energetic, early fluid management. So for when we encounter such situations like collapsed buildings and we find people which are there who are who are there under the rubble, then the resuscitation should start online, that is before extrication. If a vein is sought and found, the resuscitation should start there and there only with an crystalloid fluid, that is normal saline, which has to be given at the rate of 1 liter per hour. If vein is not found and if lower limb is there, then an intraosseous needle can be inserted in the tibia and resuscitation can be started through that intraosseous needle. And if vein is not found, we are not able to give fluids. During extrication, we need to continue this intravenous hydration with an isotonic saline at the rate of 1 liter per hour. And if the duration of extrication, it is more than 2 hours, then we reduce the IV infusion at a rate of 0.5 liters per hour. And subsequently, as after extrication, we need to continue hydration. And for those persons in whom hydration was not possible before extrication or during extrication, to identify a venous line and to hydrate them, an initial fluid of around 3 to 6 liters of IV fluid based on the clinical condition of patients. And then it should be monitored after 6 hours for the response to the fluid resuscitation. And then it has to be classified whether anuric or adequate urine output. If the patient is anuric, then he or she requires a very meticulous kind of attention for the further fluids. And if the patient is having an adequate urine output and you are not able to monitor the patient very meticulously, then 3 to 6 liters of fluid can be given to that patient. And if the close monitoring is possible, we can save on the fluids also, and patient could be monitored and given hydration of
Excuse
3
me,
to 4
Sureshri.
liters. Yeah.
We are running off short of time. So you are requested to please cut short
Yeah.
a bit. Thanks.
So there are certain controversies for fluid resuscitation. The basic keys to take over are crystalloid are preferred over colloid. Potassium containing balanced fluid should be avoided with suspected crush syndrome, even with a normal renal function, because there is a sudden chance of severe life-threatening hyperkalemia because of reperfusion of that limb. Then starch-based fluids are associated with more AKI and bleeding and should be avoided. Ideal are hypotonic bicarbonate fluids, which are advocated for heme pigment nephropathy for prophylaxis. And active fluid resuscitation is preferred over alkalinization, and there is a little benefit with mannitol. So to conclude, prevention of AKI in disasters, it lies around early and energetic fluid resuscitation, use of vasopressors as soon as possible if the volume repletion has not achieved an hemodynamic goal, target mean arterial pressure of 65 to 85, avoid nephrotoxics because there is an associated injury. So usually these patients are on NSAIDs, we should avoid them, follow 6 day rules, radio contrast studies, we should look for alternate options, and if it is not unavoidable, then to follow the KDIGO guidelines and do radio contrast studies accordingly. And last but not the least is monitor urine output and renal functions and to optimize the treatment. Just a word about the recent acute disease quality initiative work group consensus on COVID-19 associated acute kidney injury. The general principles, they remain the same, but this group has recommended a dynamic assessment of cardiovascular status for critically ill patients while giving fluids. And they have recommended using balanced crystalloids as initial management for expansion of intravascular volume in patients at risk of AKI with COVID infection. So the key takeaways are early timely intervention minimizes further renal injury and may likely result in better outcomes rather than treating an established AKI. Primary healthcare physicians, nurses, and allied health personnel who manage AKI should be trained to raise awareness, promotion, and provide practical management of AKI. A protocol-based approach is always favorable because then we can have certain endpoint where to stop for. Thank you.
Thank you, Sureshri. That was really beautiful enumeration of prevention of AKI. Thank you. I now invite Dr. Manish Balwani to talk on treatment of acute kidney injury.
Thank you, madam, for giving me this opportunity. So we all have faced the recent disaster in the form of COVID, and we saw how we dealt with it. So any disaster can be managed with the manpower, infrastructure, and the laid out mechanism how to tackle the disaster. We most of the people here are nephrologists, so I won't go into the detail of management of AKI, as we all are versed with the management of acute kidney injury. The causes may be different. The treatment is usually the same. And we usually treat the underlying illness rather than doing the supportive treatment. The supportive treatment remains with us, as ma'am already said: IV fluids, hydration, maintenance of blood pressure, and doing dialysis if there are indications of hemodialysis, urgent dialysis. So in management, ma'am has already. How? We already in the earlier topics, the Seni sir has touched that the most of the in most of the cases of, especially of collapse of buildings, earthquakes, we see the crust syndrome. But there are other disasters too. We should look for it and treat accordingly. So ma'am has already discussed on this aspects. There are man-made disaster, natural disaster in the form of, and the man-made disaster usually now what we are witnessing is war, gunshot wounds, bleeding, leading to hypovolemia, pre-renal, that needs again volume resuscitation and the correction of electrolytes. Sometimes they need dialysis. Next, please. Thank you. So I will just go through brief. The pathogenesis for this crust syndrome is traumatic rhabdomyolysis leads to release of myoglobin and also release of the free oxygen radicals, which leads to third space loss, in turn leading to depleted intravascular volume. We see hyperuricemia, we see hyperkalemia due to the muscle tissue injury. Again, due to fluid loss, third space loss, there is reduced cardiac output, leading to again pre-renal type of condition. The crux is hypoperfusion. So we have to maintain the perfusion. For that, madam has already discussed the protocol of fluid replacement. I won't go into detail again. Which fluid? Ma'am again discussed. The bicarbonated fluid is best, but NS is easily available. It is difficult to make bicarbonated fluid in such setting of disaster. NS can be used. The side effects of NS can be easily managed. So the first time the International Society of Nephrology made the disaster team, relief team, and they sent a team to Bengal earthquake in Turkey in 2003. There, what they observed, in the disaster, there were 16 crush victims. Out of those, 14 were receiving the isotonic saline on admission, and that was followed by mannitol alkaline fluid resuscitation. Duration between rescue and initiation of fluids was significantly shorter in non-dialysis victims as compared to those who required dialysis. So time is very important. We should start fluid resuscitation as soon as possible. We should avoid nephrotoxic drugs. Most of the times in such settings, there is significant trauma, and that leads to use of NSAIDs. So this is just a chart which shows what are the advantages with various dialysis modalities in disaster settings. We all know about intermittent hemodialysis, CRRT, and PD. So what are the advantages of hemodialysis? It is actually we get the high clearance of low molecular weight toxins like potassium, but it does not clear the high molecular weight proteins like myoglobin. CRRT, it is especially useful in unstable patients, those where we need better volume control, better blood pressure control. But the disadvantage is it needs continuous anticoagulation. So in disaster settings, it is sometimes difficult. PD, most of the patients have trauma, so it is usually not used in acute settings. So the problem in disaster is mostly logistical challenges. So what the intermittent hemodialysis has the advantage that most of the technicians are trained, manpower is trained, and system is trained to handle the intermittent hemodialysis. We can shift the machines at the site. We can have the mobile RO, and that can be managed in especially in normotensive patients. CRRT has the advantage that it does not need any pump or electricity. It has backup. Minimal equipment is needed. For PD, there is no need of water, electricity. If peritoneum is intact, we can definitely switch over to PD. So this was again, I will talk about Marmara earthquake experience. Here, there were 477 out of 639 victims who needed dialysis. Among those, 450 were treated by single dialysis modality like intermittent hemodialysis. 11 needed, 437 needed intermittent, 11 needed CRRT, and 4 needed peritoneal dialysis. 25 needed more than one. Initially, they required intermittent, then required the CRRT. The mean number of hemodialysis sessions were 11, and the mean duration of dialysis support was for 13 days. So the trauma goes on for weeks. Disasters like now what we are witnessing is war. We discussed is mostly due to now gunshot wounds leading to bleeding, pre-renal AKI, and we need mainly here the fluid resuscitation. Also, sometimes in trauma, we see the bladder injury to ureters that needs urological intervention and supportive care. So disaster victims with AKI here, the most problematic thing is logistics. We need a procurement, maintenance, distribution, and replacement of personnel and material, man and material. We should plan for man and material. That can be done. But see, when the site of hemodialysis is affected, this was in Harvey Hurricane. We see this is the dialysis unit, a major tertiary center. It was engulfed in floods. So there was no dialysis for at least 3 days. We need renal disaster relief coordinators, as Seni sir was talking initially. So this is proposed by the International Society of Nephrology. If there is a possibility of disparity between the healthcare demand and supply, then we have two options, that we can have the support from the local, or we can ask for support from the outside, maybe from other town or district. Nephrology units in and around the disaster prone areas, like sir was saying in the Uttarakhand, should be prepared, and they should have their own plan in hand. If there is any disaster, how we will react. That is the need of our. To conclude, management of these patients is more complex than patients in daily life, just because of medical and logistic drawbacks. Deaths due to AKI can be decreased by logistic preparation in anticipated disasters. Thank you.
Thank you very much, Manish. So we definitely need to plan the action, whatever can be done at the time of disasters, if happen. Let's now move on from acute kidney injury to CKD. Conservative management of chronic kidney disease. May I invite Dr. Anand Chelappan to speak upon.
Evening greetings to all. So very pertinent topic at this current time when we have disaster striking us now and again. I thank the society for giving me the opportunity to talk on this topic today. So when it comes to disasters, as Dr. Manish had told us, different types of disasters. There are different types of disasters. So I think we stand a lot to learn regarding disasters when it comes to disasters. So my brief talk today would be a blend of science and a decent amount of fiction. So imagine on what situations can come. So I would not be talking a lot of science, which I think most of us are aware of. So yeah, so this would be the outline of my talk. I'll be briefly touching on the etiology, the stages of CKD. What do we aim by when we talk about conservative care? And what are the problems that we anticipate in a disaster? and some solutions which I've suggested, but again, this is open to discussion. And how do you manage medications in these patients, right? So why is it important to know etiology of CKD? Because unless we know whom we are treating or what kind of patient load we have, so we can't plan any kind of intervention. So this is the results of the ICKD study, which was a multicentric study which was published. So this shows that diabetes is the most common etiology, followed by CKD of undetermined etiology. Then the other leading etiologies are glomerular diseases and polycystic kidney disease. So broadly, we have this group of patients with chronic diseases. Among these, so these are the kind of patients who will be affected in any kind of disaster, in India at least. So with evolving data, we may have more details on which kind of patients should we be prepared to handle. Right. So we are all aware of all this. Stages of CKD, there are 5 stages. So what is more important is obviously that beyond stage 3 and 4, patients start developing complications of CKD, like anemia and metabolic bone disease. So maybe the earliest stage of CKD, we still do have time when it comes to disasters, as most of us know. Patients with advanced CKD are more prone for acute on chronic kidney disease. So AKI, and they're more prone to insults and worsening. So that we need to keep in mind. So what is the aim of a conservative care during a disaster? So that would be like to protect and maintain the kidney function which the patient, he or she has, which is the usual goal of conservative care when it comes to managing routine CKD as well. And to prevent and treat symptoms of advanced CKD. Why is this important? Because we may not have all the facilities at our disposal when it comes to an emergency to treat. Like advanced CKD, now I have the right, I can admit, start dialysis at my own will. But then that same situation might not be present when somebody is going through a disaster, like we witnessed the COVID pandemic. So we need to have some kind of a plan how we are going to manage a group of patients, stage 4 and 5. And to maintain acceptable quality of life while doing this would be a big challenge. And to ensure appropriate arrangements, like we are troubleshooting, but doesn't work. So how do we go about? So we need to have a plan for that as well. So broadly, this is the care of a patient, a routine patient that all, as nephrologists, all of us do. So we have the methods to reduce progression and methods to treat the complications like anemia, bone disease, cardiovascular. And the way we stop progression is we reduce the blood pressure, control the proteinuria, and also address the native kidney disease. That's why I had put the slide on chronic kidney disease, because that's again an essential part of managing any patient with CKD, because the management of chronic glomerular nephritis may be different from that of an interstitial nephritis. So what are the problems that we can anticipate? So my talk would be very broad, but then the idea of my talk is to just put seeds so that we can think over all this and ponder over it, how we can maybe troubleshoot in the future when we have any kind of a pandemic, because any kind of a disaster, because disasters could be infectious, there could be mechanical problems, it could be any kind of thing. Right. So emergency care, that would be a strain on the health facilities. There will be shortage of healthcare personnel, not enough number of nephrologists to cater to them. Should we train the primary care providers also on these? It's again a matter of open discussion. Limited access to healthcare facilities, especially those who are living in the periphery. How do we address them? Unavailability of medications, which was again seen in the current pandemic. Also, there are a few drugs which are running out, like amphotericin, ATG. So there's a insufficient medications of essential medications. Disruption of cold chains is very extremely important. When we are talking about infectious complications during a pandemic, cold chains are very important to be preserved. So those get disrupted. Infectious hazards, nutritional and mental, we can't ignore these, because nutrition is one of the important components of CKD care. So how do we kind of tweak this nutrition during a disaster is again a matter of big discussion. So when it comes to disaster preparedness, it's actually a continuum. So it is not like you do it today and you forget it tomorrow. So it's pre-disaster, disaster, and post-disaster. Like in the case of any infectious disease also, there's a pre-pathogenic phase and a pathogenic phase. So it has 3 phases. Like as we see, it's very well elaborated in this. So in the pre-disaster phase, this is what is happening in the population environment and the hazards, and suddenly the impact comes. Impact could be infectious, it could be trauma, it could be anything. So here we have all the other non-medical people who are giving us warnings and kinds like that. So they have to get involved in this so that the vulnerability can be reduced. And with this session and with this topic, we now know that CKD is definitely a vulnerable population. So the nation has to recognize it, the world has to recognize it, right? So an alert has to be given. And prevention and mitigation should always go around, whether there is a disaster or not. Even today, we need to think about it so that tomorrow we are prepared for it. And then we have this disaster which strikes, and there's usually a latent period after which there's a lot of mortality happening, emergency happening, and then there is a slow recovery and rehabilitation which is happening. So then we have, as in the case of any disease, we are all medical people, we know secondary and tertiary prevention. So this is possibly the stage we are right now in post-COVID. Secondary is over, we are now going into the tertiary prevention, but then this applies to any kind of disaster. So I would just focus my talk on how we manage all these three phases very, very briefly. But then it's open to debate because this is something which I've just thought over and put, not recommended in any guidelines or it's not mentioned. So how I have divided it is it has to be divided into, I felt it should be divided into three. That is, it's an individual level responsibility. That's a patient or a caregiver responsibility. Then there's a hospital responsibility. Like each of us work in a hospital. So what the hospital should be doing in the pre-disaster, disaster, and the post-disaster phase. And then there is definitely the involvement of multiple stakeholders here. So without involving policymakers and societies like us, I think we can't achieve this as a single person. So when it comes to the pre-disaster phase, let's just go through what the patients can do. So they should first of all get in good communication with the care provider. That's very, very important because to execute our plan, a good communication with them is of prime importance. They should understand the components of the disaster plan. Let's say we make a disaster plan today as in a society, that has to be communicated to them and they should understand what will be done in a disaster. And the caregiver should also understand the care of the CKD patient because the CKD patient might be affected in a disaster. The caregiver has to give the support. So it's not just only the patient that we have to educate, we have to educate the caregiver as well. Ensure timely vaccinations, very important because during a disaster, the cold chain will be disrupted many times. So if they're not vaccinated properly, they won't get the hepatitis B or XYZ vaccine or pneumococcal vaccine, which we say. And we also routinely see in our routine practice that we several times tell them, but still patients don't take vaccines, right? So it's very important. We keep telling them, at least with the name of disaster, hopefully they will be more prone to take these vaccines. Very important. They should at least keep a 2-week buffer of medications. Very important. So what I generally prefer is I write 2 weeks more of medications and ask them to follow 2 weeks earlier. So that spontaneously gives them 2-week extra medications. Being in a government setup, it becomes essential for pre-planning things because most of them are actually not educated, right? So understand the common adverse effects. Very, very important. Like you're giving ASN or ARB and patients just taking it, is getting dehydrated. There's no access to water, hyperkalemia, we can't monitor. Patient has to be aware that he can switch from telmisartan to amlodipine, much safer, right? Rather than just trying to communicate with the care provider. If he's educated, then it's much easier. Get familiar with technology, right? So we have to make our patients familiar with technology because it can be the saver, like it was in the COVID pandemic. Most of us were managing with telenephrology. I'm sorry, I might shoot my time by a few minutes. So they have to register themselves with the local ESRD network if it exists. Again, we don't have a network, but then if it exists, it's good. But the number of CKD patients is just so huge. So I don't know how it works. Right. So we need to maintain a proper they should maintain proper treatment records. If there's a hospital information system, I'm glad AIMS does. So we make it all electronic. So even if they lose, many of them get, they say records jal gaya, wo pani mein chala gaya. It's very, very sad to see such poor patients come and tell those things. So if we can make all these digital, it will be very, very nice so that we can get back the records for them. Right. So learn about the list of medications which can be used as alternative, which I'll be talking a little bit in detail in the end. So as a hospital, we should have a CKD registry, at least a hospital information system. The staff should be trained in all this care. We should have buffer stock of medications. Telenephrology, we should be at least a little bit expert in that to teach them, educate the patients, and do the laboratory investigations as per the guideline. Like you have done ferritin iron just last month. You don't have to repeat it during a disaster because it's done on time. So follow the KDGO guidelines. We are always on track, right? So ensure vaccination of all CKD patients. This is one point we should ponder because there are the big fives, right? During any disaster, of them 3 are infectious diseases: malaria and diarrhea, and a few other infectious diseases like yellow fever. So should we think about vaccinating patients, CKD patients, for these vaccine preventable diseases, which become prominent when populations get displaced from one place to another during a disaster? Is something which we need to think about. Not just pneumococcal influenza and hepatitis B. I think we need to explore more whether there is like if this area is more prone for earthquakes and more displacement. Should we consider them for treating them for other vaccine preventable diseases is a matter of debate, which currently doesn't exist. So provide buffer medications, and we have to train the caregiver. That's a responsibility. As a policy maker or a society, I think we should think about establishing networks, public-private connections, right? Increase awareness. Hazard mapping is very important, and we should be involved. Doctors should be involved. Hospitals should be involved. I think policymakers should inform us that there is a thing which is coming up, so you better gear up, or so that we are also prepared, and maintain a stockpile. Increase local manufacturing of drugs. I think this is a very, very pertinent thing. Make in India again. So we have these drugs made in India. It's very, very easy during a pandemic or a disaster. The availability will definitely be there rather than depending on some other nation to provide it us. So that's very important. And we have to establish a good intersectoral coordination, which I think the policymakers would help us to do that. Health infrastructure strengthening, of course, we have witnessed that during the pandemic, and integrating all this, like whatever we now put forward into the national disaster plan is also very important. And of course, mock drills once in a while is important so that we don't forget what we are supposed to do during the pandemic or the
Sorry,
disaster.
Anand, but you need to cut short.
Yeah, maybe, I'll just go through it. Okay, so during a disaster, again, I would not be elaborating much, but just the crux of it, identify patients of CKD who are rapid progressors, doing a routine OPD visits. Find out who of them may end up needing dialysis anytime soon. So that's a kidney failure risk equation also, which is available online. So that's one way. The other way is, of course, we have the GFR trend. We know which patient would end up. So at least from your list of patients, you know whom to call and whom to alert first. So that would be the crux of disaster management in this slide. As for the doctors like us, right? So again, telenephrology and other doing pertinent investigations would be very important, and the policymakers to restore all the things to normalcy. And post disaster, what we are aiming at is a smooth transition to routine care. So that's what we are looking at, and from the individual as well, from the hospital and the administration as well as the policymakers, that's what we need to do. And the other more important thing is gather data on what we went wrong on, like we're doing with COVID. So every disaster should be taken as a learning experience, and work on it and identify gaps and address it in the post-disaster phase. So now coming to the most kind of, very hypothetical suggestions that I've made. So when it comes to anemia, last 3 slides, so I'd be rushing through this. So anemia, we can use drugs which need wider spacing, like maybe parental line, and you can use long-acting erythropoietin stimulating agents. Of course, oral HIF inhibitors, patient doesn't have to inject, doesn't have to store the erythropoietin. So these are some alternatives. CKD, MBD, calcium easily available, sevelamer may not be available, switch. So whichever is available, you switch that. Antihypertensives, educate patients on alternative drugs in the same class, like amlodipine. If you don't have the availability is not there, you use cilnidipine, but tell them about the doses which you can tweak around, right? So that's the point of it. Tell them about drugs which they're not supposed to use if they are ill, especially RAS inhibitors. And diuretics, again, tell them for furosemide, torsemide conversion, that works. Coming to vaccination, so a part of it I had already told. If there's a disruption, do a titer and later follow-up. That's one possible thing. And agent-specific vaccination, like in the COVID pandemic. So we had suggested COVID vaccination to be done. And coming to anti-diabetics, like we saw, diabetes is the most common cause of ESRD. So we need to know how we manage these patients, right? So very, very important thing now, every prescription has, most of them have SGLT2 inhibitors, but these are drugs which are not supposed to be used when the patient is sick. So train them on sick day protocol. It applies to SGLT and tell them alternative drugs like glyclazide or glipizide, which we can use in renal patients when they're coming for follow-up. And be it antihypertensives or anti-diabetics, ask them, at least affordable patients, to do monitoring at home. Do it in the pre-disaster phase so that during the disaster, post-disaster, it will be very, very helpful. They can just contact you with the blood sugar records and the BP records. So we do it nowadays. We rely more on home BP rather than the clinic BP these days. So vasopressin antagonists, I don't think it's needed during a pandemic. It's being used for AD-PKD, but then we can definitely give it a miss. So last slide here. So coming to the most controversial thing, immunosuppressants, how do we manage? So I would not be giving recommendation, but I would just say do an individualized risk benefit assessment when it comes to immunosuppression, be it COVID or be it an earthquake or whatever it is. It has to be individualized assessment. You need to consider the risks and benefits of any drug. And don't discontinue any drug promptly. At least steroids, if they're more than 20-30 milligram, they'll go into withdrawal or they will have a relapse. So consider tapering it. That's very important. If the patient is visiting for any reason, get a CBC done at least so that you have an idea of what the immunity is like. right? So when it comes to CNA, educate them on alternate like cyclosporin versus tacrolimus, anti-metabolites, MMF or azathioprine. MMF not available, they can still take azathioprine. Steroids, of course, different types of steroids. We are all fond of prednisolone, but then there are also other steroids. So you can definitely use those when such a situation comes. And of course, IV pulses can be avoided. Rituximab or biologicals, these are long acting, so better avoid it if there's an infectious disaster. For non-infectious also, if it can be avoided, maintenance can be delayed. But if it's being used for a pulse or something like that, then of course, it will depend upon the situation. And finally, cyclophosphamide, yes, oral is an alternative, or we can use some other drugs like MMF, whichever is available. But then a risk-benefit assessment is very, very crucial in patients who have this kind of thing. And the last thing is patients who are on CKD stage 5 who have a fistula. If they have a fistula burst because of a disaster, they should know some basic household things where they can stop. They can put a cap of a bottle cap and stop the bleed. So some practical tips on if something happens and the fistula bursts, how do they manage? So those can also be educated. So a good communication and a continuous revisiting all this plan is extremely essential. Like in any code blue or team hospital, we should have a different code for all this. And I think it should be revisited time and again. Thank you so much.
Thank you, Anand. Very beautiful tips you have given. And I like the point that the CKD recognition, registry, incorporation of policymakers is really at the heart of all this. Thank you. I now invite Dr. Ashwini Kumar Khandekar to speak on management of dialysis facilities.
Thank you. I'm sorry I arrived late at the meeting. I don't know if I'm as elaborately prepared as Anand and some of the others, but what we understood from the COVID times is that especially from the difference between the first wave and the second wave is that in the first wave, we thought we could not do it. And in the second wave, we thought it would have been so easy, even in the first wave, to actually do it. The advantage of managing dialysis patients is that they are well identified group of patients. We can reach out to them. We can there's always a list available. We can always call them and we can always realign them. So I will be talking about delivery of dialysis, and what can happen in natural disasters is that not only these patients might fall short of the facilities because the facilities themselves are getting damaged, or because there are more number of acute kidney injury patients who are now requiring dialysis. And in either case, the demand supply ratio is going to change. So we need to realign the demand supply ratio and make sure that everybody gets dialysis, at least the minimum required. If not 4 hours, 6 hours, at least a short dialysis with higher flow rates can be given. The problem here would be power outage, would be water shortage. So even that, if we want to prepare, that is the biggest crux. The power outage will be the biggest crux, and how we and that will probably come from the city management or from the hospital management, whether power outage can be efficiently managed. About realigning the so what I would suggest is that this ratio can be realigned in three ways. One is whatever the existing facilities are there, they can be realigned to provide relief to the existing patients or the increasing number of patients. And the second is to set up new units. If we are setting up new units, either it can be with conventional equipments that we have, that we are so used to, and other is then using unconventional equipments like a portable RO, or previously what has been used as the sorbent dialysis, where water shortage used to be taken care of. And I have elaborated how can we do it. Learning from the COVID times, we need to form a management group like the war group that was, or the war room that was made by the city management. There we need to have clinicians, we need to have administrators, we need to have even vendors, some of the vendors who would supply disposables and who would manage RO systems, and senior technicians. So administrators, clinicians, some of the senior clinicians from even medical colleges should be utilized, because those facilities can then be utilized. The space is not a problem in medical colleges. So that can be put to a very, very good use. If you can see in the conventional equipment, if you can see the dialysis unit, how much is space required for each machine? It's not very big. Not even 100 square feet is required for each machine and a bed. So that much space can easily be availed, and a large facility can be made within a lot of government premises. So in fact, in COVID times, a lot of temporary structures were erected, and that can also be thought of. We now have the experience doing that, all these temporary structures getting erected, not only in COVID, but routinely for various meetings and conferences. So this is just a list of what are the conventional equipments that are required. One point that I got from Anand is stockpiling. So stockpiling should be also added to this particular list. A lot of us have a particular practice in number of reuses. So here, probably in disaster times, number of reuses can be increased. We are not currently reusing tubings. Maybe we could reuse tubings. Only a few years back, we were reusing tubings. So that can be done. So conventional equipment, we know how to use. We just need to be more frugal, and we need just to keep a watch on quality of water, quality of the reuse and the reprocessing. About the non-conventional equipment, sorbent dialysis was utilized in earthquake situations where crush injuries and water shortage was there, but it had its own problems. In the end, it was abandoned because there was a problem of aluminum leaching. So, and I wonder whether that is easily available also. Although portable ROs are easily available, and portable ROs are probably not routinely used because the cost to utilization ratio is very high. For the same cost, we can put a conventional RO with a very good capacity. So, but in a disaster scenario, it becomes very easy. There are units that are available. A dialysis machine and a RO on the same platform is available and can be wheeled across facilities. So that can be done. There are so many places where dialysis on wheels has been practiced. So that can be probably looked into more seriously. So those are some of the suggestions from delivery of dialysis point of view. Hope I have not left out. These conventional things we are used to PEX system. I specifically mentioned PEX because it is easily moldable. It can just be thrown across the room, and it does not need any specific casing or anything. So those are the things. If
Thank you very much, Ashwin. Nice suggestions you made, and thanks a lot. May I now invite Dr. Dhananjay Ukalkar, sir, to speak on advice to patients on maintenance HT.
So thank you, all of you. And I'm amazed at this CME because there are starters on the table. Nobody's touching the starters. People are listening to each speaker with rapt attention. I never thought disasters would be such an interesting topic to listen to. But I will limit my comments. But I can't withhold this comment about my experience in Nadiad in 1992. I started my career as a nephrologist in 1992, and we had just done a kidney transplant for a man from Surat. And then 1992 happened in India, and there were riots all over the country, and Surat was under a curfew. After the curfew was lifted 10 days later, this man came back to Nadiad with reduced urine output, puffiness of face. He had acute rejection, and we tried to salvage him, but we couldn't salvage him. Reason was with curfew, he couldn't get his medicines and he went into an acute rejection. So man-made catastrophe, man-made disaster having an impact on a renal transplant recipient. Many people tend to belittle the growing problem of CKD in our country or all over the world. And we fail to understand that in the US now, there are 5 lakh people on dialysis. In India, we have 1 lakh. But in India, dialysis population is growing at the rate of 31%, whereas in the US, it is growing only at 6%. And in Europe, it's growing at 8%. So we need to focus our attention, because with the government's initiative of Ayushman Bharat, with so many non-government organizations coming in, private sector growing at phenomenal rate, dialysis population is bound to grow very rapidly in our country. And so what happens to the dialysis patient is of immense public health importance. May I next slide, please? Can you help me? I will try and keep my comments on these slides brief, but can you help me? So we have these man-made disasters like riots, we have the natural disasters, and we have learned a lot. Huh? Okay. So power outage, somebody commented, and it's essential to have a backup generator for hospitals to service their patients on dialysis. It's essential for hospitals to have provision for backup generators, and also to have backup understanding with other dialysis facilities, so that you can shift your patients there and patients can receive dialysis on time. We have learned a lot from Hurricane Katrina as far as nephrology and dialysis is concerned. And after Hurricane Katrina, there were 44% of people who missed at least 1 session of dialysis, and 17% missed more than 3 sessions of dialysis. And the risk group was those who were just coming into the dialysis program, less than 2 years on dialysis, who had fewer dialysis before hurricane hit them, who lived alone, who were unaware of the facilities for an emergency plan, and who were placed in a shelter. Here in COVID-19 in Rajasthan, this study was done, and they found that although 62% did not face any disruption within their dialysis schedules, travel barriers and had to switch hospitals, decrease their dialysis sessions, medicine access, hospital closure or refusals, and increased charges were issues which troubled majority of the patients. After Katrina, the renal related admissions grew to over 2.5 times after the epidemic, after the hurricane. Here also, from Rajasthan, those patients who stayed far away from the hospital had increased mortality as compared to those who were closer to the hospital, possibly related to the restrictions on travel imposed during COVID times. So these are the emergency planning recommendations for dialysis patients that we have already spoken about, post of the acute kidney injury, the dialysis specific preparedness, and the need to anticipate, if it is possible, the need for early dialysis in cases of disasters which can be predicted, like hurricanes. You can predict a hurricane and dialyze your patients before the hurricane hits the city. The dialysis population is changing now, and more elder people are coming on the program. And those patients who were elderly had a disproportionately higher emergency room utilization after the hurricane. And COVID, major disaster in recent times, affected mortality in dialysis population. Kuwait had a mortality of 27%. India also close to that in the reported literature. So before the disaster and after the disaster are the two times when we will have to have a plan which would be there. In America, they have well laid out disaster management guidelines. Patients in the dialysis units know what they have to do. But despite that, and there are 15 items in that kit, which bag which they are supposed to keep. Only 31% of these people, despite ongoing education, had all the 15 things in their kit. So this is our Indian guidelines from the National Disaster Management Authority as to what all should be there. I did not find a whistle here, which is there in the American guidelines. So there is some difference, but by and large, if we can teach our patients to prepare a kit, a bag, we will be protecting them if in case there is a disaster. And another thing, even in America, they could not convince their patients to have is a bracelet, medical alert bracelet or a necklace, where it is mentioned that this man is requiring regular dialysis, and what are the other comorbidities that he has. If we can convince our patients and create this in a cost-effective manner, I think it will help many of these patients. Like Anand said, that many of them are diabetics. So if there is a diabetic who meets with a disaster, you can treat him differently than a non-diabetic. And we need to teach our patients also how to manage without dialysis, because during disaster times, dialysis facilities will be swamped. And one of the most important thing is the potassium binder, which should be there in every kit. Kexilate. And there are some limitations to Kexilate, but even in America, where many of the patients already had extra medicines, 2-week supply, Kexilate at home was seen only in 6% of patients. This is food which is recommended for 3 days emergency diet for dialysis patients. This is the American recommendation, and this gives about 1100 calories and 40 grams of proteins. I've asked my dietitian to look and Indianize this and at least talk about the North Indian food and the South Indian food, and what we could do as a recommendation. That I will put up on the computer, internet, and we can discuss it as to what we should do as far as Indian diets is concerned. These are some general recommendations as to how food should be stored so that you don't have food poisoning and loose motions and volume depletion and further deterioration of renal function. This is a new concept. This is when triage is established concept in disasters. But if patient has renal failure, is or requires dialysis, and you have 15 patients and only 5 machines, which of those patients would you dialyze first? The answer is the old GMC regime that we used to follow. Those who are the most sicker, who are likely to die first, get the first chance of getting onto the machine. So this is the triage. And these are some of the well-known indications for an emergency dialysis. Communication is affected during a disaster, and these are some guidelines as to how communication could be handled during a disaster. But what is interesting is the use of the radio for during a disaster, and the community should have an emergency radio, and people should be aware which radio is to be used. This is the basic information which patients should have about their dialysis on them, on their person, in case there is a dialysis. These are 2 videos. I will not take much of your time because one is about a fire which hit a dialysis facility in Goa. And the second video is about how the patient should be disconnecting himself in case there is a major disaster and it hits the dialysis facility, how he can disconnect. This is on the YouTube. You can have a look at it once you go home. And one of the last points I want to make is friendship in the neighborhood. Your neighbor is your best friend, and he is likely to help you with managing a disaster. And this is a scientific paper which talks about my neighbor, my friend, the relevance of support, closeness, and history of relationships in neighborhood friendship. Let us not forget the patient who is in stage 4 and 5 when we focus our attention on dialysis population, because 4 and 5 are likely to trip into need for an emergency dialysis once a disaster hits them. Unfortunately, we have list of patients on dialysis. We do not regularly maintain list of CKD stage 4 and 5, but then they are the people who will crowd the dialysis units during a disaster. So tough times do not last forever, but tough people live and last. And I think planning disaster, looking at potential disasters in a serious fashion, planning for our response during a disaster would be an important contribution which Nephrology Society can make. Thank you once again.
Thank you very much, sir. Very nicely elaborated all the details which patient should keep. Beautiful description. May I now invite Dr. S.J. Acharya, sir, for talking about management of kidney transplant patients during disaster.
The disaster. Good evening, everybody. Dr. Ukhalkar had just told about a patient in his first slide, that a patient during Surat disaster, he was transplanted patient and he could not take his medicines and had rejected the transplanted kidney. So it tells us that in emergency, you should have at least 15 days of immunosuppressive medications and other drugs with you at any moment of time. And this message should be conveyed to the patient while he is in the transplant room post-transplant. So right from the time when he starts taking food orally after transplant, we start giving him education that, see, you have to have at least 15 days of therapy with you. And what I do that we make a small transparent boxes and label it, mycophenolate, tacrolimus and all. So he can understand that this box is getting empty and he will fill it up. Yes, the first one. This is the logo of National Disaster Management Forum. Next, please. Now, how to care a patient in midst of disaster? And in disaster, there is a lot of harm or damage that occurs without any peculiar timing. There is unexpected timings and seriously destructive. And no one has imagined that this can occur. And during such a time, there is a disparity between healthcare demand and supply. So whatever facilities we have available facilities, these are insufficient during disaster. And there are situations, as happened during COVID days, that we had to take into account that who is more critical and whose life is more valuable, which is actually basically it is unethical. But then in a situation where a person, say aged 85 years and who is gasping for breath, and another person aged 30 years who is gasping for breath, whom will you intubate and whom will you put on ventilator? And obviously the person who is younger and needs a ventilator will be given the priority. And this happened not only in India but all over the world, that we had to decide that who has to survive, which is actually basically wrong. But elementary ethical rules are non-negotiable, but there are certain situations where we have to take these into account. Now, the effects of the disaster are physical injury, environmental pollution, unhygienic living facilities, food and water shortage, sudden lack of medical supply, communication breakdown. And these all have been touched by my previous speakers. And especially about the food and water shortage was beautifully brought out by Dr. Ukhalkar. Now, there are some specific preventive measures you all know about the evacuation of the hurricane in case of hurricanes and or wars, and vaccination programs during pandemics. But now, and these timelines are important, where we have to predict a disaster to begin with by various means, then organize the resources and switch into action and face the actual disaster and manage the after effects. And after all these things, once you have done everything, then you have to face the music. Face the music means what? You all remember that there was a fire in Bhandara Hospital where lot many children were trapped in the fire, and the person who were actually punished were the staff nurses and the doctors, and those who were responsible for the management, actual management of the hospital, they were scot-free. So you have to be prepared for everything, including the last one. Then now I come back into the actual transplant scenario. Now, the transplantation management in a case of disaster is different from other things because they are immunosuppressed patient. They have various comorbidities, hypertension, diabetes, ischemic heart, CKD, some lingering infection, GIT problems, GIT bleed, and so on and so forth. And most of them are frail, so they are prone for infections. And on the top of that, there is a sword of infection or rejection hangs on them every moment. So the transplant patient is different from other patients. Now, there are reasons for increased risk of graft or patient loss in transplant recipients after mass disaster because of various reasons. Either the threats towards health by direct harm by the disaster, treatment of disaster injuries or the complication, physical injuries, non-hygienic living conditions, inability to obtain medications, non-adherence to treatment, and increased risk of infection during pandemics. Whether it is an infective pandemic or non-infective pandemic, they are at risk because, for example, a building which has fallen down, there will be dust, and that dust will be full of fungus and other bacterial elements. So there is a risk of graft dysfunction or potentially fatal complications, and that will lead to increased risk of graft or patient loss. Or there may be decrease in the supply for the healthcare, like shortage of medical personnel being affected by the disaster, psychological problems, chaos in healthcare organization, or shortage of medical resources like damage to the infrastructure, structural damage to the hospitals, or problems of transport or distribution. These all will affect ultimately a renal, any organ transplant patient. And during disaster, there is a heavy workload, chaos, administrative disorganization, logistic drawbacks like less beds, less working hands, medical supply, and lot many patients. And medical uncertainties like medical and paramedical personnel may be short, OT hygiene, deliveries of medical supply and immunosuppressive drugs. These are all affected. These are nothing new. These all you know, but these are just organized in a particular format. Now, what do we do during disaster? Kidney transplantation, actually, the process of kidney transplantation, we must postpone the transplantations from living donors. A person who is a living donor giving a kidney to his colleague or a family member, they can do it at a later date. You can postpone the transplant because after transplant, during transplant, you don't know how the OT is, whether the person will be able to reach the OT or not, whether post-transplant medications will be available or not. And in case a patient really urgently needs a transplant, for example, liver transplant, in that case, you have to shift the patient to a place where there is a safe, where it is safe to carry out the surgery. So temporarily suspend live donor transplants, and also in case of infective pandemic, risk of donor getting infected and succumbing to the infective pandemic is very high. So it's better to suspend a live donor transplants. The disease donor, the priority, suppose a person is brain dead, then you put the patient on ventilator, and lot many people are involved in the management of a diseased person. And that time during a disaster, you don't have that much of hands to take care of a patient like that. So mobilization of available resources to saving lives of more people than one individual one. And in spite of taking care of the disease donor, there is no certainty that whether that person will really reach into the operation table for donating the organs or not, and whether the recipients are available at that time. So it's better to prioritize the surgeries in such a way that those who are benefited more, or more benefits can be accrued to the persons who are suffering because of the disaster rather than a disease donor. Temporarily stop disease donor program because the ICU beds getting occupied in maintaining a disease donor. Transport restrictions, increasing cold ischemia time. Our organ has been retrieved, but person cannot be the organs cannot be transported, leading to increase in the cold ischemia time. And decreased availability of disease donors as in pandemics. So that's another cause for temporarily stopping disease donor. Then once the transplant has been done, then there is or the patient who is already on immunosuppressive drugs following transplant, avoid the antimetabolites because they decrease the immunity a lot, and switch over to dual immunosuppression like tacrolimus, calcineurin inhibitors and steroids, or you may even stop all the immunosuppressants except for the steroids and increase the steroids marginally. And avoid a person who needs to be on a very high dose of immunosuppressive drugs. Like just now, Dr. Anand told about rituximab, whether to give rituximab in such a situation. And not really, it must not be done. It will be rather a crime or medical negligence to put these patients on rituximab, because that will result in a heavy immunosuppression. Now, a patient who has been transplanted and suddenly there is a disaster and the transplant patient is in the hospital. So delay the discharge of that patient, because where he will go after the transplant, after discharge, he will go to his own home or a living facility where he is staying. But that itself might be infected, that might be destroyed. There may be some kind of, for example, in case of hurricane or earthquake, the places where he is staying, that might be destroyed. And if you send the patient back home from the hospital, then he will be subjected to that infective environment. So better delay the discharge if possible. Then after all these things have been done, the patient's near relatives who are taking care of the patient financially or otherwise, many of them, they might have died, or they might be suffering from the disaster. And so they are exposed, the transplant patients are exposed to a very severe mental trauma. So any tragedy involving supporting members puts a big psychological impact on the patient. He will say that the person who has paid so much of money for me and who has been taking care of me, and while taking care of me, the person has died in a disaster. So that's a big psychological problem to a transplant patient. And at that time, following disaster, they need financial support and medicinal support much more than what he would have needed without a disaster. During all disasters, you all know that how the telemedicine helped many people. In fact, it has saved so many thousands, lakhs of patients. And through telemedicine, we could tell them that what is to be done, what medicines to be taken, what is the line of treatment, surgery, how to refer the patient to a proper place. These all could be done because of the telemedicine. And patient education is a must. And this played a big role during COVID. Non-vaccine preventive measures like face mask, hand hygiene, physical distancing remains a must. And even after vaccination, these remain a must. And those who have recovered from COVID-19 will still be needing vaccination. About the disaster, mass disasters and COVID and transplant patients, I did not get much of the references, but this is one of the reference where whatever I have delineated till now was from these studies. And one of the study was they just spoke to people that have you got a proper suppose there is a fire or disaster, are you ready? So they found that only 30% of the patients were highly prepared for disasters. Actually, this have been already told by Dr. Ukhalkar about whether they have got enough of medicines, whether they have got a identification bracelet, whether they had important phone numbers of their doctors, etc. The National Kidney Foundation recommends that patients must store medications in original bottles and if possible store 2 weeks of extra medication every time. This I have told you earlier. In summary, there is a deficit of general preparedness and information about the disaster. Need for better education and preparedness should be there not only from the patients from the point of view of medical personnel, but also from the healthcare people, those who are drawing the outline of how to manage the disasters. They should be prepared for that. And these all things I have already told you about disease transplant activity, decreased number of disease donors, and the disease number of living donors. So in other words, the timeline in a transplant patient will be postpone the live transplant following a disaster, suspend the disease donor transplant, reorganize everything, the operation theater, medications, and medical personnel, etc. Then restart transplant once the situation is better. And lastly, gather support and try to support those who have been transplanted until the normal the situation comes out of the disaster. So we look ahead in upgrading our disaster management, maintain the STEAM with practice. We should know the risk and issues and how do we solve these issues and what are the immediate next steps. Now, we all know that recently we had an earthquake in Syria and Turkey, where India is so far from Turkey and Syria, but the opportunity was taken over by our government and our disaster management teams were sent there. So that was a kind of oiling of these teams that yes, they can help. And that will go in a long way for our disaster management teams. They have learned so many things there, and our own people, those who are managing this, the Harta Karta of disaster management teams, they will know that what is to be done and what is not to be done. Thank you very much. Shubham.
Thank you very much, sir. That was very informative talk. Now we come to third modality of RRT, CAPD management in disaster by Dr. Prakash Khetan, sir.
Good evening, everyone. A lot has been already dealt with, so it is a easier job for the last speakers to finish off their talk in quick time. Next slide. So we have already listened to this. There is a regional disaster relief task force of International Society of Nephrology and the European Renal Best Practice Guidelines. So the guidelines have favored the use of hemodialysis in disaster situation. So as we know that the nephrological issues during disaster, hemodialysis treatment may be impossible because of structural damage, shortage of medical supplies, clean water, electricity, healthcare professionals. There might be lack of PD solutions, increased risk of infections, non-infectious complications that may make PD therapy challenging. And there could be non-availability of immunosuppressants, increased risk of infection that may result in graft loss and death of kidney transplant patient. These are all the nephrological issues during disaster situation. So PD, CAPD and APD is mainstay of end-stage renal disease therapy in both resource limited and resource abundant settings. In natural disaster scenarios, military conflicts and other austere areas, PD may be the only available life-saving measure for acute kidney injury patients or patients with end-stage kidney disease. And but PD in austere environments is not without challenges. There can be challenges including catheter placement, availability of dialysate, and medical complications related to the procedure itself. But when hemodialysis is not available, PD can be performed using whatever general available medical supplies are there, and PD can be done in such situations. Coming to historical events, the Hanshin earthquake 1995, during this earthquake, the ability to provide hemodialysis to chronic dialysis patients after was impacted because of damage to infrastructure. It destroyed 2 dialysis centers, 36 were partly destroyed and 28 lightly damaged, and 2 remain undamaged during this earthquake. Up to 50 facilities were unable to provide hemodialysis following the disaster, and around 3,000 patients were dialyzed at alternative locations. The first information on PD came from the Kobe earthquake in 1995. Here, the Yogo Prefecture managed 265 PD patients, which contributed to 4% of total dialysis population. And patients were surveyed after the event, and most managed PD at home. 7 continued PD at an evacuation center. 3 were hospitalized, and 1 was transferred. Medical companies were proactive, managing to contact all PD patients within 2.7 days on an average, and informing the treating hospitals of patient status and deliver necessary PD equipment. The second historical event is the Chichi earthquake in 1999. Here, 401 patients were managed with PD in central Taiwan region. Patient had several weeks to 1 month of PD dialysis supplies at home and were able to continue to manage their dialysis independently. Patients managed with the automated PD were switched to manual exchanges due to loss of electricity, and medical companies again successfully managed to deliver dialysis supplies in the weeks following the disaster. However, 2 patients developed peritonitis in the month after the earthquake. Tohoku earthquake and tsunami 2011, 359 PD patients were in severely affected districts, compromising 3% of the dialysis population. Only a minority of PD patients were evacuated, mostly due to destruction of housing. Most PD patients continued to dialyze at home, and most had adequate supplies of consumables with early assistance from the medical companies. In one report from Iwaki City in Fukushima, 40% of the patients in this unit continued treatment at home, compared with 3% of hemodialysis patients. Patient had 5 or more days supplies of PD fluid, and some patients reduced the number of daily exchange to extend supplies. The resumption of outpatient service was faster with PD patients with a 60% patient return rate compared with only 11% of hemodialysis patients. And persistent shortage of hemodialysis facilities and staff since the disaster resulted in efforts to increase PD uptake in Fukushima. So in disaster-prone areas, CAPD might prove to be better as compared to hemodialysis. Coming to Indian literature, the flash floods in Leh in 2010, a 30-year-old man with end-stage kidney disease was on CAPD for 7 years. On that fateful night, he stayed up late doing his night exchange. Other members of the family were asleep, and as he was finishing, he noticed the sudden gush of water into the room. He immediately woke up the other family members and ran to safety with them. It was not until next morning that they realized their home has and everything in the vicinity has been reduced to rubble, and most people in the neighborhood who had been sleeping had perished. So not only these patients out, but also his dialysis supplies had been lost. So he was able to find a patient on PD in another area who had escaped the catastrophe, and he continued PD using borrowed supplies. Being on PD provided an easy RRT option in difficult and unfavorable circumstances. Again, one more incident, a 29-year-old Indian Army soldier engaged in relief operation developed acute gastroenteritis there. And within 12 hours, he became hypotensive and oliguric. Fluid resuscitation was given in the field hospital. The diarrhea gradually abated, but oliguria persisted. Over the next 3 days, this man became acidotic and drowsy. There were no HD facilities available. He was started on feeding using a rigid catheter on a stylet, and the patient improved gradually over next 72 hours. He remained oliguric but otherwise stable. And then the air facility started. He was evacuated to other centers, initiated on dialysis, and had a gradual and complete recovery. So PD acted here as a stabilizing treatment for patients with acute kidney injury. This patient underwent a transplant after 1 year, getting a cadaver. And in 2011, this patient underwent a transplant who was on CAPD. So disaster planning in CAPD, the patient needs to be instructed to assemble a disaster kit, and they should be provided with contact numbers of dialysis suppliers, and for a PD program, their planned evacuation city, and they are reminded to take all medications, bottled water, antibacterial soap, hand sanitizers, and 4 to 5 days of PD supplies. Usually the telephone and cellular phone services are usually disrupted. Only text messaging might be available, wherein the patient can contact with the suppliers, or the suppliers can contact the patients. Arrangement with major dialysis suppliers for emergency supplies to new locations should be made by the PD coordinator and the patient. And thorough preparation, planning, practice, and implementation and effective communications are necessary to prevent complications in PD patients who are affected by disaster. And with advanced preparation, maintenance of communication with healthcare providers, and planning for alternative sites of care, patient can be safely maintained on PD without complications following catastrophic natural disasters. So to conclude, PD is recommended as a preferred treatment modality in disaster-prone areas. Patient can manage independently with adequate supplies. Treatment is flexible and mobile. Power and water are not needed, and medical companies have historically been supportive. Special care needs to be taken to prevent exit site infection and peritonitis after disaster. Thank you.
Thank you very much, sir. Very nicely elaborated importance of CAPD over HD. Now, last topic, very important, psychosocial interventions for kidney patients at times of disaster. May I invite Dr. Kanak Gilurkar? She's a consultant psychiatrist at Gilurkar Hospital and in Niti Gowra Complex.
Thank you, ma'am. Good evening, everyone. I'm relatively new to this crowd filled with nephrologists, and I'm extremely honored and humbled to be speaking here in front of all of you. So shall we start? Pen right. Yeah. So much of it is already being covered, and I actually appreciate everyone of you taking so much of interest in what goes into the psychosocial aspects of disaster, especially for patients suffering with renal disorders. Yes. So I actually did a lot of research for this particular topic, especially because disaster management, mental health, and in addition, kidney disorders, it is something which is not so widely studied, I must add. The question here is, how can disaster actually amplify pre-existing problems, and why can certain people be more vulnerable? Now, I'm not sure if this is clear or not. We know that disasters do impact medical and physical conditions, and they do impact community. But how widely they do impact our mental health is something that is more important. And so psychosocial impact of disasters at individual level, at family level, and at community level, overall at a state and a national level, has to be paid more attention to, especially because they do amplify pre-existing conditions. So yes, not everyone reacts to a same situation similarly. And so there might be some people who actually have exaggerated responses or are more traumatized, whether some are not. Yes, there are some obvious impacts like deaths of loved ones or being separated from parents and families, being airlifted, being displaced in refugee trauma, of course, physical injury, and loss of families, finances. But some invisible psychosocial impacts, which can actually be neglected, if not overseen, can be some changed roles in life. So often losing a parent or a primary caregiver in the house, and the child has to take care after their younger siblings, or drop out of school and work to support family, and so much more. Impact on family functioning because of poverty, impact of changing roles and responsibilities, and mothers having extra burden to also take care of the home and take care of the families, and impact on community overall because of reduced infrastructure and resources. So what happens over here is a major critical portion, which is loss. So loss can be anything, loss of anything, loss of life, loss of personal relationship, loss of control over own life and future. A sense of security is gone, a sense of hope is gone. Then there's loss of trust in the future, often in the government and social institutions as well. And property loss, loss of opportunity to generate an income again soon in the near future. All of these things actually impact mental health for anyone. So what about people who are already susceptible to those things? People who are differently abled with chronic illnesses like end-stage renal conditions, people with pre-existing psychiatric conditions, since we are not new to the fact that all the chronic conditions, including end-stage renal conditions and people on dialysis, are susceptible and in fact do suffer from depression and anxiety and so many psychiatric disorders. And the rescue workers, the doctors, the primary care physicians, and the nephrologists who are on the front line. Now, how are kidney and brain correlated? I mean, this is not something new. Primarily, we share a favorite chemical, which is dopamine, both of us, but also the fact that kidney problems are associated with multiple comorbidities. So far, we also have discussed AKI and rhabdomyolysis and other conditions, but we also have seen that during COVID-19, what had happened was, although it was primarily a respiratory condition, but so commonly post-COVID comorbidities consisted of cardiovascular and renal, and all of them directly or indirectly consisted of mental health conditions. Yes, survivors of end-stage renal disease are kind of susceptible and suffering from depressive and PTSD symptoms. But because the allostatic loads increase during disasters, what happens is they may actually disrupt the blood pressure and the glycemic control in directly and directly putting more pressure on the already diseased kidneys, kind of making it more susceptible to long-term and short-term comorbidities and mortalities. So we actually, as clinicians and policymakers, need to be aware of the heavy psychological toll that disasters put on our renal conditions. I'm not going to take away most of the time since we don't have much. I'll brief you about how stress reactions happen. So there is acute phase, reaction phase, repair, and reorientation. Just as we all know what happens in acute phase, it may last for about a few days or a week, and fight and flight response happens over there. So कई बार ऐसा होता है कि the primary rescue workers who go, patients don't really have, they are in panic and shock. So they don't even have the sense to convey to them that I am a CKD patient or I am on dialysis and I need primary care. Like sir had mentioned that they need to be some bracelets or some form of coloring demarcation, because during this phase, they won't come out and tell people, and we can't identify which are ours. Reaction phase, somewhat similar, but here PTSD, depressive features, anxiety features, disturbing thoughts, survivor's guilt, and so much more is seen. Repair phase, slightly less intense than the previous, and reorientation phase again. These two phases actually chronically need to be intervened, and the patients need to be monitored, because these are the patients who are actually going to be needing a long-term psychiatric or a mental health professional to rehabilitate them. We know that disaster reactions, psychiatric disorders, and risk behaviors are actually intertwined closely, but research has shown what protects people from suffering from these psychiatric conditions is resilience. In short, our ability to fight back and come back to normal as fast as possible. Now, I had put down some pointers for immediate attention as to what are the behaviors which would call for immediate attention of the primary care physicians or the intensivist or even the nephrologist, and when to call on to the fact that they might need a psychiatrist. Yes, we know loss of self-control, aggressive, hostile behavior, but even if a person has insomnia for more than a week, they are very susceptible and prone to something called as delirium, and they might actually pull out their cannula and catheters in the middle of the night, and you might have to rush and call a psychiatrist. So before that, alert could happen if you know that this person is not sleeping well, or they are not functioning normally within themselves, their family, or they can actually seem to threaten or be agitated than normal and can cause harm to themselves or others. Someone who is now having excessive amount of alcohol or smoking more, any of your patients, if their addictive habits increase, they are a high alert for the fact that they are kind of suffering somehow psychologically. And so much more. Again, I won't go into more details. What happens is, these are easy to identify that a person is having PTSD or anxiety or depression clinically, but there's so many conditions which are going on at a subnormal level, wherein you might actually not be able to have that eye, and we can alert ourselves and be conscious of the fact that if these signs are showing, we might prevent our patient actually landing in a mental health condition and then having this triage, and we can intervene before itself. So there are a lot of physical, behavioral, cognitive signs and emotional signs which can alert you, which you can have aptitude about to identify, like decreased efficiency at work. If the patient is telling you, often we would think that yes, they have a pre-existing comorbidity, they might have weakness and physical ailments and get fatigued easily, but no, decreased efficiency at work, decreased cognitive issues, then memory issues, falling personality changes, being apathetic, not feeling interested in things, not wanting to go to work, having multiple physical complaints, vague complaints, yahan dukh raha hai, ye ho raha hai, and things like that. And we just walk past it, ki, "Arey, don't, this is attention seeking or something," but it is actually psychological underlying distress, which needs to be identified. So much more. Let's just walk past it. So how mental health services can be helpful is by intervention programs, which are generally outreach based, whichever is the center for triage at a disaster. Maybe it's a school or a temple or a college. Then of course counseling and consultation, and primarily educating. Like sir said, that it is better that we educate ourselves in our societies before something happens, and we keep them ready, not just medically or physically, but psychologically and mentally, so that they are more resilient and the comorbidities decrease. Sometimes हम बुराई करते हैं मीडिया की, but media can actually play a good role in educating our masses. Again, too much information I had, but मैंने पीछे किया शायद ना? Yeah. Right. So that's why it is important to include mental health professionals in mitigation and rehabilitation teams, so that we identify and we segregate our individuals who are at high risk for developing mental health issues. Prompt intervention is needed to decrease the mortality and morbidity. I have a question then. So what comes to your mind when we say mental health and psychosocial support? Who can do this? So MHPSS, which is mental health and psychosocial support, is nothing but the actions that provide immediate relief of the suffering of a person, both emotional and physical, and they improve their short-term functioning so that long-term psychological effects can be avoided. So it's almost like a psychological first aid. We'll talk about it. Basically, characters kya hai? It mobilizes the power of humanity so that we are in touch with our humane side and we help others more. It relieves emotional, physical suffering. It improves immediate ability to function under stress and reduces long-term negative effects. Now, we know that physical wounds are easily seen, but those are the mental wounds which are often secretly kept and hidden, and due to the stigma and vulnerability. Do I have more? Do I have time? Am I running out of time?
Sorry, Dr. Kanak.
Yeah, sure.
Running a bit late.
Yes, so I'm just going through it, not in details. It is just something called a psychological first aid, which we can do, and we can actually train our people. So because mental health professionals are generally not at the front line, so we can actually train our non-professionals who are matured, who are confident, and who can deliver the psychological first aid, then the primary care physician, and then beyond that. So I did see that WHO they had a Kobe center wherein the first time they actually identified that yes, psychosocial interventions are extremely needed. So when I was doing this research, I saw a lot of governmental and international organizations and websites, and how, and even nephrological societies internationally, how they have psychological first aid in their website in details. So I thought, okay, apni government ne bhi kuch kiya hoga. And this is all I could find on their website. This was just a single page, and that was slightly disappointing. So this is my message. Let's change the module together. Yeah. Yes. Yeah. Yes. Yes. Wow. Yes. Kerala. Yeah. That's what I read. And that is what later on I added. So after Kerala and the government's interaction in Kerala, that is when it was changed. Kerala floods, no? Okay. Thank you, sir. Thank you for that. So yes, let's change the module together.
Much. And I now hand over proceedings to Dr. Piyush for concluding this today's session.
Hello. Thank you, madam. Should be soon be able to draft our final guidelines. We are also having with us our guest of honor, Dr. R.P. Singh sir. He happens to be a secretary, Indian Red Cross Society, Nagpur branch. I request Dr. Ukhalkar sir to felicitate Dr. R.P. Singh sir. I request Ketan sir to felicitate our chairperson, Monali madam. And thanks all our speakers and our delegates and team of Septalist for their support. And I now invite you all for the dinner. Just yeah, yes.
Friends, sorry, won't keep you long from your dinner, but very good presentations that were made. But I think there was something amiss where we are not aware as to what is the actions that the government of India has done. As I said previously also, when I started the entire initiation of this discussion, that beyond 2001, we are far away at the moment, and we have catered to a lot of issues. What we would rather look forward to, in case the nephrological experts in Nagpur have the capacity and can create something for support, it can be put onto the IDRM platform, which is available for each and every district. The district collector posts the available resources onto the platform so that the neighboring district can also see what is available in this district. If anything happens in the neighboring district, they can call for it. So these are the facilities which are available, and we were part of the high-powered committee also, which actually framed the DM Act, and subsequently we have the NDMA coming up into existence. A lot of things after that guidelines have come in for psychosocial support, and as well as the chemical, nuclear, biological. I myself, in fact, was trained on WMDs. In fact, we were experts on that. And we have done a lot of training programs, training our general population. And only one particular thing which I would like to mention for all of you, that go for what is within your reach. Please create that. And if you can provide support to the local administration, that will be really wonderful. And somebody did mention about the mobile dialysis centers. Look forward to that. We can get sponsors. Let's start making that. Fixed ones you already have. The challenges of power and communication will be overcome. There'll be rather a gap of about 24 hours. You need to meet within 24 to 36 hours of provision for generators where you can keep on these things. But the first part, there will be emergency teams of the power generating and the distribution companies, which will be looking at emergency methods of restoring power also, because that's the first aspect which normally gets destroyed. Communication and power. So these two will be dealt in the very first stage itself. So don't get worried. At the very high level, this is happening. As far as the Ministry of Health is concerned, we have an EMR division, not a new one. It was existing, rather I joined after the army, the National Civil Defense College. During that time itself, EMR was there, which was responsible for all emergency medical elements which needed to be done at the government level. Even to an extent, we have our civil defense plans. Under that, hospitals need to prepare how many beds are needed on a 750 population. One bed for emergency purposes has to be kept in reserve. A medical reserve has to be created with all medicines, all with complete lists of surgical instruments and medicines already there. and given as guidelines at all district levels. And today happens to be the World Civil Defense Day. The entire world is celebrating it. And this is the same organization which is carrying out all rescue operations in Syria. They call them as white helmets there. And although that is Syrian civil defense volunteers, which come from within the community and are supporting. So I won't say that you be part of that, but at least whatever a structure which you can develop on your own, I would suggest if you have the wherewithal, have a portal created. So whatever support you have, you can put it on that. You can also put all those patients which are dependent of a dialysis and as well as patients who are on CKD, they can be on that and subsequently they can get identified. And the administration has data available to them as to what resources they need to mobilize for them. Thank you very much. It was a very fruitful discussion. And I think all these guidelines we will prepare and see that it goes up to the national level also. Thank you. Thank you.
Just okay. Yes.
I will not take much time. I'm audible. Joseph, yeah, you are audible. You are audible. I am secretary for Red Cross Society and working there for 24 years. And we have worked for red light area, HIV, AIDS, STDs, and all that control. So all the aspects, whatever they describe, psychosocial, this and that, preventive and all that is being practiced over there. And everybody said that whatever is there with you should be utilized at the disasters. Because अब कहीं भी बाढ़ आ गई, कुछ आ गई, तो कहाँ आप लेने जाएंगे कुछ भी. I remember in one of the riots during UP, there was no stitching material. So they used that patanka dori for stitching. So whatever is there at that moment of time, you can use, but of course, with all precautions. Thank you very much. And hope good guideline will be there. And it's a very good idea to have disaster management with kidney patients. And as he was telling that every district in last month only have trained around more than 200 people in disaster management by NDRF and we people in collaboration with collectors guidelines. So every district in India, I believe it is going on. And it has happened in Nagpur also. We have trained almost more than 200 persons, young ones. We paid more than 2 lakhs.
Sir, मैं इसी महीने की बात कर रहा हूँ. This month only. So every time we are training, and I believe everybody will be trained, then only it will be a great successful program for disasters. Thank you very much. Thank you very much for calling me.
So just a request to join us for a group photograph.